and welcome to the AAKP session on innovations in alternative therapies to dialysis, implantables, and wearables. I'm Melissa Bensouda, an AAKP Ambassador and fellow kidney warrior. I was diagnosed with chronic kidney disease at the age of 24 after giving birth to my second daughter. After my third child, I lost all functionality of my kidneys. While on the transplant list, I initially began dialysis treatments in center, but was selected to participate in a nocturnal home hemodialysis program. After 6 weeks of extensive training, I set up a machine in my bedroom and dialyzed on my own every other night for 8 hours while I slept. In April of 2012, I received a donor kidney, which lasted nearly 5 years before rejecting, causing me to resume dialysis. Having experienced home dialysis, I knew that's the treatment I would return to, as it gave me the freedom to live my life the way I wanted and has allowed me to continue working full-time and raise my 3 children. I am involved with the AAKP because the patient voice matters. As a kidney patient determined to continue advocating for advancements in technology, education, and research to improve outcomes of those affected by kidney disease, I am so honored to introduce our session speakers. These individuals are leading cutting-edge research initiatives that aim to truly shake up the status quo in kidney care and help provide an alternative to the organ shortage crisis. I'd like to now welcome and introduce our final speaker for today's session, Dr. Victor Gura. Dr. Gura is founder and innovator of the Wearable artificial kidney known as WAK 3.0 and a practicing nephrologist at Cedars-Sinai Medical Center, Los Angeles. Dr. Gura is a longtime friend and ally of the AAKP. We've been honored to feature him in our previously hosted events, including our 2021 Global Summit. For today, I'd like to invite Dr. Gura to provide an update on WAK 3.0 by asking him a series of questions. Why do we need a WAK?
Well, you need a WAK if you're on dialysis, because the way you do it now is not a very good way of doing it. If you are a dialysis patient, then you go 3 times, 4 times a week to a dialysis clinic, and you spend hours on end tied to a dialysis machine. You would want something that gives you more freedom. So instead of spending so many hours of your life attached to a machine, you're free to go and do whatever you want. When your kidneys don't work, you need dialysis to survive. And you have to go through this difficult process of spending so much time attached to a machine. And patients on dialysis want their freedom back. So if you would have a miniaturized device that you can wear on your body all the time, so you don't have to go to a clinic 3 times a week, that's why you would be better off by having a WAK. If you're dialyzing at home, same story. You're still attached to a machine doing other things. Is impossible. So when you're on the machine, you cannot go to the bank, you cannot work, you cannot clean the house, you cannot go to the store because you're attached to the machine. When you're out of the machine, many times you're fatigued and you don't want to do anything except going to sleep. So if you would have a device that does not leave you fatigued and tired after the treatment, that's why a WAK would be better for you. And I can continue discussing this to a great length, but I assume there are more questions coming.
Can you share with us how big and how heavy it is?
The prototype of the wearable artificial kidney, the WAK, has been evolving. The Model 1 was in a big breadboard and it was used in animals. It was not even wearable. It was just a prototype. The Model 2 is still a prototype and it weighs 11 pounds. it was never intended to be the device that people are going to walk with on the street. It was intended as a proof of concept that, in fact, you can do a wearable device. And as such, we made it work and it performed very well as a prototype of 11 pounds. However, the patients still said it's too big, we want it smaller. And we had to figure out how to make it smaller. The Model 3, which is coming up now, and we hope to trial it sometime in 2022 in Nashville, Tennessee, in University of Vanderbilt, is a 2-pound device, and that is small enough for people to walk around with it and wear it. So the idea is to reduce the device to such a size and weight that people will feel comfortable walking around with it and conducting their activities of daily life. So the Model 3 coming up has been miniaturized enough to weigh only 2 pounds.
Is the WAK 3.0 something a patient can carry in a bag or a backpack?
The answer is yes, you can. Should you? Probably not. And the reason why not is because the connection between the device and your bloodstream is a tube that conducts blood. So if the device is in your backpack and your connection is a lengthy piece of tubing that might be a couple of 2-3 feet, connecting blood from a catheter to the device, there is a very significant chance that it may kink, cut off, entangled with something else. So can you put it in a backpack? You can. Should you? Probably not. Furthermore, if you take it on a bag next to you, you also have a tube running your blood between your body and the device. So the risks posed by entanglement or a cut or kinking of a lengthy tube are such that can you? Yes. Should you? Probably not. There are better ways, more adaptive to the body, where you can put a WAK 3.0 like a belt, which would probably be the most convenient place to put it. So those that think that you can make a WAK and carry it in a backpack, when they start looking at a very important issue, which is human factors of interaction between the human body and a device, and may discover that a backpack or a bag is doable but not advisable.
Is it possible to take it off? And if not, why not?
The Model 2 was never intended to do anything except work for a few hours. It worked up to a day. The Model 3 is something that people will be able to wear it 24/7 and sleep with it, take a shower with it, and you may not want to take it off. Can you? Yes. Should you? As little as possible. Reason being that the Model 3, when you open and close the blood circuit, you can get infections. And the less infections you get, the better off you are. The Model 4, which we are working already now, will have more technology to prevent infections, and as such, you'll be able to take it off and put it back. However, you need to be realistic. The WAK is like your kidney. It's an extracorporeal kidney out of your body, but a kidney nonetheless. Nobody takes his kidneys off his body to go to a party or to sleep. And you need the kidneys for as long as possible. That's the way your body is designed. So the more you take it off and put it back, the less off you are. Discussing this with patients, I had a patient that said to me, very nice lady that likes to party. She says, I don't want this on my body when I dress up and I go to a party. I want to look my best on my latest um, Chanel model that I just purchased, and I won't go dancing, and I don't want this on me. So that's okay on the Model 4. She will be able to do that. I listen to her because I have such a patient, and I say, how can I make her happy? And that's when the ideas for the Model 4 came up, where patients will be able to connect and disconnect on their own. But the idea is to mitigate the risk of infection, because you cannot go partying and dancing if you have an infection in your catheter. That's not a very good idea. So you still have to make choices. Do you have a WAC that you don't have to sit on next to the machine for hours on end? Yes, it's better off than having to do that. But it's never an end to the desires and demands of different people. Eventually, you will have different devices of different sizes and models for different people. The WAC for an 80-year-old lady in an aging facility will be different from the WAC for a truck driver or a bodybuilder or a security guard that weighs uh, 200 pounds and is 30 years old. So eventually we will have different models for different people. This is just the beginning.
If an adult patient is on dialysis for 3 hours, 3 times a week, what does it do for the patient?
A lot, a lot. First of all, you don't have to go and spend 9 hours a week to 12 hours a week on the machine. So those 12 hours that were not yours are now back to you to use your time the best you like. That's number one. Number two, when you dialyze with a WAC, we have shown that there is uh, no limitations on the amount of fluid and foods that you can take, and I'll discuss that further later. So your freedom to eat and drink what you want is back. Third, we have enough data to believe that the post-dialysis fatigue that you have after being 3 hours on the device is not going to be back. So you will have less chances of being disabled, uh, unable to do anything after dialysis, and you'll have a more normal life. If you are 3 times a week for 3 hours on the machine and you don't remove all the time all the toxins you want to remove, you have to take a lot of pills. You need to stick 2 needles in a fistula. That's painful. I never saw anybody that is happy because they have to stick 2 needles in their arm. So that's going to disappear. So the amount of advantages, the freedom of eat and drink, the decrease in the amount of pills, and the freedom to go and do whatever you darn please with your time are some of the many advantages that the WAC hopefully will confer to the patients.
For individuals watching that are parents or guardians of pediatric kidney patients who are on hemodialysis, can you explain if or how this device can help that population?
In many ways, children on hemodialysis, Fortunately, there are not very many of them. Most of them do peritoneal and they do a little better. But those that require only hemodialysis, they have many problems. Because the filtration required for a child to grow is less than what regular hemodialysis provide, growth in children is impaired, and that's a big deal. If you deliver better clearances of toxins to children, the chances of growth will improve, or so we expect. The second thing is, if you're an adult, you have probably 4 or 5 liters of blood in your body. So if you're dialyzing with a machine that has 250 to 300 ml of blood inside the machine when you're dialyzing, you don't have a problem. But if you're a 10-year-old child, you don't have 4 liters of blood in your body or 5 liters. You have much less. So the amount of blood that goes into a big machine is very significant and causes many problems. The WAK only uses 35 cc's of blood, not 250 cc's of blood. So the ease of dialyzing a child with a WAK is much better than dialyzing a child with a regular machine. Dialyzing children with regular machines today is doable, but it's a big technological challenge. And there are no machines for chronic dialysis for children yet. This would be a first.
Thank you, Dr. Gura. This is all such great information. Just a few more questions, more nutrition related, since this is such an important topic for kidney patients. If I use a wearable kidney device, will I still need to watch my potassium and phosphorus?
No. We have shown in human data, by the way, there are many people trying to do wearable kidneys, implantable kidneys. Nobody has human data so far except the WAK that we are doing. But our human data, already carried out and published, have shown that you can eat whatever you please and your phosphorus will not go down. Actually, you might even have to give you phosphorus. What that means is that there's no limitation in the foods that you can eat today that have phosphorus, such as dairy, ice cream, cheese. And we would make phosphate binders obsolete. The same goes for potassium. You might be able to eat tomatoes and potatoes and orange juice and all those high potassium foods and drinks that you craved but couldn't have because potassium can cause a cardiac arrest if you don't watch it. With the WAC, we have shown that it kept the potassium and the phosphorus also normal. So no phosphate binders, freedom to eat and drink whatever foods you want without any risk of high phosphorus or high potassium.
What about fluid overload? Would patients still have to limit fluid intake?
No. The, um, the WAC removes fluids at the same rate your kidneys do. So if you drink 1.5 to 2 liters of fluids a day, which is what the normal adult drinks, and we remove 1.5 to 2 liters of fluid from your body, you can drink whatever you want whenever you're thirsty. And that has been shown in 3 human trials around the globe. So if we remove all the fluid we needed to remove in 3 famous hospitals around the globe with 3 different very famous nephrologists, and the data showed each and every time that you can drink all the fluid you want, and there is no fluid overload, then there is no fluid overload. Thing works. So you never have fluid overload. And when you go to the dialysis unit, you have to remove 3 or 4 liters of water that causes cramps and pain and sometimes drops in blood pressure. All that is gone with the WAC. So no more fluid limitations.
And what about sodium intake?
In the WAC, we have removed up to 15 to 18 grams of salt a day. Patients on dialysis are told to eat only 2 grams of salt a day, maybe 3. So that makes the food not that tasty, much tasteless than you would like. Since you remove 9, 10, 15 grams of salt a day, you can eat basically all the salt you want. And there will be no limitations on salt. So you can eat pretzels and earrings and olives, uh, whatever salty food you like, and the WAC will keep your sodium level wherever it needs to be without high blood pressure, without fluid overload. And this is not because I just say so, but that's what we showed in our human data that we carried on patients with the WAC 2.0, and the WAC 3.0 is going to be no different in that regard.
And final question, Dr. Gura. Can you share with us how this innovation will be paid for?
Well, by statute, CMS pays for dialysis, regardless of which way you do it. We've had in the past several discussions with prior leaderships in CMS with the change with administrations, of course, and we have heard that they were not only going to pay for dialysis with a WAC, but they were in record saying that for new technologies, they even pay more than with old technologies. Furthermore, there is already a billing code for a wearable artificial kidney. So we do know that those that are Medicare recipients are going to get reimbursed. And there's no question that no matter how you dialyze, whatever machine and whichever your insurance you have, uh, the payers are going to still cover treatment with this. Furthermore, because of the enormous savings that the WAC is going to bring to the Medicare budget and to the insurers, there's going to be a strong desire on their part to implement the WAC because it's going to save them a lot of money. For example, the cost of 1 month of treatment with phosphate binders is about $900 a month. If you do the math, it's about $5-6 billion a year that we're paying in phosphate binders in the United States alone. If we make phosphate binders obsolete, then the expense of paying for phosphate binders is gone. So if it's gone, that's a huge saving in billions that doesn't exist today. There are many other examples: less high blood pressure, less fluid overload. That means less heart failure, less hospitalizations, and so on. So there is a strong economic set of reasons for payers, including Medicare, to pay for this.
Thank you, Dr. Gura. We appreciate you taking the time to join us and answer these questions to help kidney patients learn more about this upcoming technology. I would like to again thank today's panel of speakers. To learn more about the Kidney Project, I encourage you to follow them on Facebook at Artificial Kidney. And to learn more about the WAC 3.0, visit www.wearableorgans with an S.com. Thank you again for joining us.